Welcome to this podcast of the People's Pharmacy. It's brought to you by Ear Ease.
Every year, millions of people suffer from ear pain, especially air travelers and young children.
The Ear Ease, invented by a medical doctor in 1988, has helped tens of thousands of people reduce or eliminate ear pain.
Go to earease.com for more information. That's www.earease.com.
Bladder cancer gets little respect, yet it's far more common than most people realize. What symptoms should you watch for? This is the People's Pharmacy with Terry and Joe Graydon.
Bladder cancer is the fourth most common cancer in American men, right after prostate, lung, and colon cancers. Despite its prevalence, most men don't know the early warning signs of trouble.
That's a shame, because the sooner bladder cancer is detected, the better the prognosis.
Coming up on the People's Pharmacy, we talk with a bladder cancer survivor about his experiences and with one of the country's leading researchers about advances in bladder cancer treatment.
First, this news.
In the People's Pharmacy health headlines, women who take acetaminophen during pregnancy may give birth to children who are at slightly higher risk of developing attention deficit hyperactivity disorder. That's the conclusion from a large epidemiological study of more than 60,000 Danish women. Those who reported taking acetaminophen, the ingredient in Tylenol, were 13% more likely to have children with hyperactive behavior at age 7. These youngsters were also more likely to receive a medical diagnosis of ADHD or to be prescribed stimulant medications such as Ritalin. The more weeks the mothers took acetaminophen during their pregnancies, the stronger the association. Association is not causation, but pregnant women should limit their exposure to drugs unless such medicines are essential.
Older people treated aggressively for hypertension may be at higher risk for injuries from falling. Investigators tracked roughly 5,000 Medicare beneficiaries for 3 years. These senior citizens had high blood pressure. Most of them were taking medications to control hypertension. Those receiving multiple medications were at significantly higher risk for falls, leading to hip fractures and head injuries. People who had fallen in the previous year were more than twice as likely to experience another serious injury if they were taking antihypertensive medications. Older patients who experience dizziness, drowsiness, or unsteadiness as side effects of their medicine should discuss the benefits and risks of aggressive blood pressure control with their physicians.
Bisphenol A, or BPA for short, has been recognized as an endocrine disruptor, mimicking estrogen. This compound is found in the resin that lines cans containing foods and beverages. It's also found in the thermal receipts that you may get at the grocery store, ATM machine, or gas station. Questions have been raised whether handling receipts would result in a measurable BPA exposure. To find out, Harvard researchers conducted a pilot study with 24 volunteers. These subjects were asked to spend 2 hours printing and handling thermal receipts. They also provided urine specimens from before and after the experiment. A week later, the same subjects repeated the experiment while wearing disposable gloves. The results showed that handling these receipts without gloves dramatically boosted the concentration of BPA in urine. Wearing gloves provided significant protection. Although the levels may not be dangerous for consumers who only handle a receipt occasionally, cashiers who print and touch receipts 40 hours a week may be exposing themselves to excessive levels of BPA.
How good is diet when it comes to controlling blood pressure? A meta-analysis of 7 clinical trials and 32 epidemiological studies found that a vegetarian diet is associated with lower blood pressure. Participants following a vegetarian diet in controlled trials experienced nearly a 5-point reduction in systolic blood pressure and over 2 points in diastolic blood pressure. Observational studies showed that vegetarians had systolic blood pressures almost 7 points lower than omnivores. The investigators concluded that vegetarian diets might offer a non-drug way to help control blood pressure.
Many people think of echinacea as a natural way to prevent or fight off colds. The independent evaluators at the Cochrane collaboration analyzed 24 randomized controlled trials of echinacea for the common cold. What they found was that the echinacea products used in these studies varied enormously. There were 3 different species and different parts of the plant and methods of preparation. The results varied almost as much as the products themselves. One of the authors commented that echinacea may have some small preventive or treatment effects, but the evidence is spotty. At best, this herb may reduce the likelihood of coming down with a cold by 20%.
Vitamin D may play a crucial role in immune functioning. A study of nearly 1,000 senior citizens in Northern Ireland measured inflammatory markers such as C-reactive protein, interleukin 6 and 10, and TNF-alpha. Those with 25-hydroxy vitamin D levels below 10 nanograms per milliliter were significantly more likely to have unfavorable results compared to those with levels greater than 30. And that's the health news from the People's Pharmacy this week. Welcome to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. Today our topic is a little discussed type of cancer that's far more common than you might imagine. Although it gets too little attention, bladder cancer is the 4th most common malignancy for men in this country. Let's demystify its diagnosis and treatment.
To learn what it's like to get a bladder cancer diagnosis and go through treatment, we turn to David Langham. He's a bladder cancer survivor and coordinator for the Triangle Bladder Cancer Support Group.
Welcome to the People's Pharmacy, David.
Thank you. It's good to be here.
David, you're a bladder cancer survivor. First, if you would, tell us, when did you suspect something was going wrong?
Right. So I was on a trip to see my family up in Alaska, and it was a long airplane flight. And I got up to Alaska, and when I finally got to the house, I went to the restroom, and I was urinating some blood. And I associated that with having to sit on the airplane for a long time, for being uncomfortable with all of that. And that was in October of 2007. So it continued on for about a month. And I decided that it probably needed to be looked at because
Well, at some point
there.
you couldn't blame it on the plane trip.
Exactly. So I went to my family provider, and she was fabulous, absolutely fabulous. And she said, well, it could be this, it could be that. Let's get it in checked right now. So within 24 hours, I was over having x-rays done. Had the x-rays done, they said, we ought to send you upstairs and have an ultrasound done on that also. And then within a week, I was seeing a urologist for bladder cancer.
Had you ever heard of bladder cancer?
No, I had never heard of it. I'd never thought that I would be susceptible to cancer, period, much less bladder cancer.
So this was a big shock.
No, it was a huge shock. And I think the experience that I've had with the other groups, I think that we see that quite frequently with people who have just been diagnosed going, what am I going to do? And that was certainly my experience.
So that was your initial reaction as soon as the urologist said, all right, David, you have bladder cancer. Here's what we're going to do about it. What we've heard from other people occasionally is that the here's what we're going to do about it sort of morphs into wah, 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 wah. Is that what happened?
Yeah, it did. In my case, my wife went with me, and I think it was really helpful to have another person with me as I went through the whole process.
Very smart.
Because she took notes, she was interested in understanding what was going on, and I was really just scared. And at that point, he could see that there was a tumor in there, and it was a large tumor. And at that point, I was thinking, oh, now what? And he said, we would like to go ahead and schedule surgery and get this thing out of there this week, which, of course, elevated.
That's really quick, yeah.
Which again, elevated my anxiety. Let's hurry up and get this done,
Yeah.
And so it was a month between when I first saw the blood and I had actually had the surgery to have it removed, the tumors removed. And there were 5 tumors in there. And the procedure is the TURBT, which is the procedure that is used where they go in. They don't cut your skin, but they go in through, I call it your access port.
Yeah.
And
the TUR means transurethral resection of something.
Bladder
tumor.
Mm-hmm. Yes, that is good. Thank you. And so they went in and they took out 5 tumors, and one of them was very large from what they told me afterwards. And then at that point, I decided that I wanted to get some more opinions on things. So I started talking to some other doctors too, just to kind of find out what was going on in terms of what the next steps are.
Mm-hmm, the follow-up treatment.
The follow-up treatments. And at that point, I actually changed doctors because I had to have a second turbot done in order to check to see if it was muscle invasive or not. It took a lot to get it out, and they needed to check and see if it was actually in my muscles.
So they needed to go back in there a second time. Oh boy, I'll bet you were.
I was thrilled.
Thrilled, yes.
Absolutely thrilled. It was so exciting.
Just to sort of root around in there and make sure they'd gotten all of it. Wow.
Yes. And at that point, they graded it a mixture of low and high. My understanding is the high means that it has the greater potential to become muscle invasive. So the higher grade to me means it's better chance of being muscle invasive. And what I did is I just sort of blocked. That's where this blocking thing we're talking about.
Yeah.
I blocked out everything, and kind of said, okay. Then they started going through. I started going through the BCG treatments.
So then you were faced with the decision of what to do after the surgery, how to follow up on this. How did you go through that process of finding out and making a decision?
Right. So there really are not that many choices. I can do nothing, or I could go through the BCG treatments. So obviously I chose to do the BCG treatments because that was what was recommended by my doctor.
Now, BCG, let's see. That stands for an old vaccination process, immune boosting system. I think it dates way back, decades, Terry?
Maybe even almost the 19th century. I think it probably was, I'm guessing, early part of the 20th century.
Did they explain why they wanted to do BCG and what the benefits might be?
Right. So the way the BCG treatments work is that they catheterize me, and then they put the BCG directly into my bladder, and then they have me literally roll around, laying down every 15 minutes, turning to a new position, which then coats the inside of my bladder with this treatment that they put in there. And the purpose of that is to stimulate the immune system so that everybody's coming down and fighting what's going on down there. And so that's what I did. And I went through a number of rounds of this treatment.
Now, when we think about other sorts of cancers and treatments for other sorts of cancers following up on surgery, often it's chemotherapy, and we think of maybe some side effects. Were there side effects with the BCG treatment?
For me, I did not have some of the side effects that you experience of fevers and that sort of thing. It was very painful. Your body doesn't like having foreign stuff in it, and it doesn't like letting that foreign stuff out of it. And it was very painful for me to go through these treatments. But that being said, I think in the long run it was a very successful process. So I'm glad I went through them. I'm glad I didn't have any of the other side effects that other people have experienced with it. It's not fun, but then having cancer is not fun.
Right.
So what was the outcome? Surgery, BCG. How are you doing now?
So, well, the story continues. So the type of bladder cancer that I have is a rapidly reoccurring type of cancer, or can be a rapidly reoccurring type of cancer. And so in April of 2009, when I went in for and I want to stress, my regular checkup, my regularly scheduled checkup, which I always go to, the doctor found another tumor.
Mm-hmm.
And so this meant another round of going through the surgeries and going through the treatments and the BCG treatments again. And then I had another potential scare, which turned out to be nothing. But in order to do that, I had to go through the surgery again. And thankfully, it was nothing. But, it's a process you have to go through all the time.
Mm-hmm.
And so I am now over 2.5 years out, which I think is very successful.
You've been through now a couple of rounds and are doing really well.
Mm-hmm.
Bladder cancer doesn't get much respect. And when I say that, I mean, people, they think about the bad cancers, the common cancers, lung cancer. They think about things like melanoma. They think about colorectal cancer. There are a lot of cancers that come to mind, prostate and breast. Bladder cancer, people don't know much about it. They don't think about it. They don't even know necessarily what to look out for. You're part of a support group.
Right.
You're now involved in helping people deal with bladder cancer, but also educating other people. So what would you like people to know? Because as we understand it, the earlier you catch bladder cancer, the better the prognosis.
Yes. Well, to your point of people not knowing about bladder cancer, I think a lot of people know about bladder cancer and don't want to talk about it or don't want to think about it. And I say that because as I talk to people, I keep on running into people who say, oh, my so-and-so, my uncle died from bladder cancer, or my father or mother died from bladder cancer. And it's something that is very prevalent, but people don't want to talk about it. And I don't know that that's because it's down there.
It's the bladder.
It's the bladder, it's private or whatever. But it is a reality that this is a really important cancer that needs some attention. It's affecting an awful lot of people. So I am involved in the Triangle Bladder Cancer Support Group, and probably the most important thing that the Bladder Cancer Support Group does is it gives people who are facing decisions or who are facing having bladder cancer a place to come and be with other people who have bladder cancer or who are facing bladder cancer.
You're listening to David Langham. He's a survivor of bladder cancer, and he coordinates the Triangle Bladder Cancer Support Group.
David mentioned that his wife was with him when he got the diagnosis and treatment plan, and I think that's so critical.
It is really helpful to have an advocate with you who can pay attention when you go into shock.
We need to take a short break. We'll learn about the importance of detecting bladder cancer early. How survivable is it?
We'll also talk with Dr. Raj Pruthi, a leading bladder cancer researcher. Do you have risk factors for bladder cancer?
What are the symptoms to watch for? We'll learn about the future of home testing and the success rate for bladder cancer treatments.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
Welcome back to The People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is made possible by Red X Industries, makers of utterly smooth creams and lotions that deeply moisturize to make dry skin feel soft and smooth. 800-345-7339. Online at uttercream.com.
And by We Patients, where you can learn from others about possible triggers and potential treatments for your headaches or migraines. Online at wepatients.com.
If you would like to order a CD of this show, you can call 800-732-2334. It's show number 937. That number to call again, 800-732-2334. You can also place the order on our website, peoplespharmacy.com.
Today we're talking about the diagnosis and treatment of a surprisingly common cancer.
We've just been talking with David Langham. He's a bladder cancer survivor and coordinator for the Triangle Bladder Cancer Support Group.
David, the idea of catching bladder cancer early seems to be very important. That's what we're hearing from the professionals. And yet a lot of people tend to want to ignore something like, urine, blood in the urine. How do we help people understand why it's important to get in for early detection, early diagnosis, and early treatment?
Well, in my case, I can speak in my case, even though a month now in hindsight I think is a long time, in reality, if I had just ignored it, those tumors could have grown bigger, but even worse, they could have grown deeper. So the tumors themselves were superficial. They stayed on the inner lining of the bladder and did not go into the muscle. And once they go into the muscle, then you start talking about a different kind of bladder cancer situation. And so that would be the reason, the primary reason to do it. The other reason to do it is it's just not normal to have blood in your urine.
David, what would you like our listeners to know about bladder cancer? As I said, it doesn't get quite the respect that perhaps certain other cancers do in terms of, the detection, but most importantly, surviving and living with bladder cancer.
Mm-hmm. Well, a couple of things. One is early detection is really important. So if you see blood in your urine, go see your doctor. In fact, there's a T-shirt that I wear sometimes that says, see blood in your urine, see your doctor. So that's probably one of the most important message. And then there are some online support groups, and Beacon has one. BCAN.org has a website that has an online support group, and that's a really good group to connect with. And then you can always contact the Triangle Bladder Cancer Support Group.
The idea of survivability. I think one of the things that people always worry about when they hear cancer, their lives start passing before their eyes. They think, okay, that's the end of the line. And for some cancers, pancreatic cancer is tough, lung cancer is also difficult. But bladder cancer, you can live a long, healthy life after bladder cancer.
Right. So in my case is a good example. I caught it early. I actively participate in making sure that I keep my appointments, that I'm there on time, that I do the things that I need to do. I try to keep healthy. I try to eat right. I try to exercise. So those things are really important. But it is important that you just be involved in your life.
David Langham, we want to thank you very much for sharing your story on the People's Pharmacy.
Thank you for having me.
You've been listening to David Langham. He is a bladder cancer survivor and coordinator of the Triangle Bladder Cancer Support Group. And now we'll get a different perspective on bladder cancer from the other side of the stethoscope.
We're talking today with Dr. Raj Pruthi. He is Professor of Surgery Urology, Chief of Urology, and Co-Director of the Urologic Oncology Program and Bladder Cancer Center of Excellence at the University of North Carolina Lineberger Cancer Center. Welcome to the People's Pharmacy, Dr. Pruthi.
Thank you.
Dr. Pruthi, there are many cancers that get a lot of attention. Obviously, lung cancer, a major killer. We think a lot about brain cancer because it's such a devastating disease. Mm-hmm. One that may not get the respect it deserves, bladder cancer. Can you tell us a little bit about it, what it is, who gets it, and why?
Yeah, I think you hit the nail on the head. Bladder cancer, in fact, is the fourth most common cancer in men in the United States and ranks somewhere between 9th and 10th in women. So it's a common cancer and a common cause of cancer death in this country. It doesn't get maybe the attention that prostate cancer, breast cancer, lung cancer does. But again, as the fourth most common cancer, it is an important concern for our people in the United States. And in fact, the incidence of bladder cancer has been rising over the last several decades by about 40%. So it's a disease. It's typically a disease of the elderly. The average age is around 70, but we do begin to see it in patients in their 20s and 30s, again, peaking in the 60s and 70s.
Do we have any idea why it's on the rise?
It's felt to be the rising incidence related to the aging population, first and foremost. So as people are living longer, they're being more susceptible to bladder cancer. The other is potentially the latent effects of tobacco abuse. Tobacco abuse is the most common known etiology or cause for bladder cancer. We often think of the impact in lung cancer, but bladder cancer, there's a high association between tobacco abuse and bladder cancer as well. And sometimes the effects can be 10, 15 years later.
Are there any other risk factors for bladder cancer?
Tobacco abuse is the most common risk factor by far in this country. Historically, it's very interesting. The association of environmental carcinogens and bladder cancer has been identified for over 100 years. In fact, it's one of the first cancers in which environmental toxins were associated with a cause of cancer. And this was due to a lot of the toxins, industrial toxins in the late 1800s that were being used. Today in this country, we don't see that very much due to a lot of regulations and EPA restrictions. We don't see environmental toxins or chemical carcinogens as often as a cause.
Digging deep into my graduate school memory banks, I'm sort of thinking dyes.
Yeah, aniline dyes are classically one of the things associated with it. So dyes.
And when we say dyes, we're talking like for industrial?
Industrial dyes in the past, no longer, for clothing, for leather, dyes for leather. There's been a lot of other loose associations of certain occupations and bladder cancer. Some people have implicated hair dyes, although, again, with restrictions today, we really don't see that as often anymore.
And what is it about tobacco that, we think of lung cancer, but why would cigarette smoking or other forms of tobacco use affect the bladder?
Yeah, the way we metabolize the tobacco and the carcinogens within that, what we do is we create basically toxins, and those toxins are filtered by the kidney into the ureter as we get rid of them. And in fact, the theory is that as they sit into the bladder, these toxins that we're getting ready to eliminate in our waste, that it's there that they can actually cause a direct chemical irritation. And in fact, the most common site within the bladder of cancer is the floor of the bladder, where that urine will sit.
So that kind of leads to the idea of if you don't empty your bladder frequently, those carcinogens might end up sitting there longer. Is there any validity to that idea that going to the bathroom regularly and drinking more water to dilute the urine would be beneficial?
Yeah, a good question, an interesting question. There's not really that association has been shown. There is some, again, very, very loose associations that people who do drink more water may have a slightly less incidence of bladder cancer. But I don't think that we should necessarily take that as a green light to really, that's going to be the answer. Really, the answers are to eliminate the original carcinogens and smoking cessation. And in fact, smoking cessation has been shown to reverse that risk within about 2 or 3 years. So that's again, a very important association, and probably the greatest modifiable risk factor in bladder cancer. There's some other very interesting aspects to the environmental causes. Another one is radiation exposure and the associations of radiation exposure and bladder cancers. This was seen in Hiroshima bomb victims, for example, a very high incidence of bladder cancer 5, 10, 15 years later. Uranium mine workers in Great Britain, also a very high incidence of bladder cancer. So whenever we hear of these terrible events around the world of radiation exposure, that's one of the concerns that people have is down the line, will they exhibit a variety of different cancers, including bladder cancer.
How would someone suspect that he might have bladder cancer? What are the symptoms that a person should be on the lookout for?
The most common symptom of bladder cancer is blood in the urine. And in fact, that's a sign and symptom that should never be ignored by any patient at home, and very, very important that a patient should seek attention from a physician to evaluate the causes of blood in the urine. And there's a variety of different causes, and every time a patient experiences blood in the urine, it's not necessarily due to bladder cancer, but it is one of the most common heralding event is blood in the urine. So when we see it grossly, that is by the naked eye, that's a concern. But the other way we can detect it is microscopically. A urinalysis, a common test that's done, a very easy, non-invasive test, basically sampling the urine, a dipstick of the urine, which is often done at a yearly physical exam.
Well, you wouldn't necessarily be testing for bladder cancer unless you suspected there might be a problem, would you?
That's correct, and that's one of the concerns. In bladder cancer, we've always struggled. When we look at death rates from bladder cancer, we really haven't made a tremendous impact. And one of the reasons is we haven't really made tremendous strides in early detection. We still wait for what I believe to be a relatively crude symptom, visually seeing blood in the urine. And early detection for a variety of different cancers can be a key method for impacting the morbidity and mortality of that disease. There's been a lot of evaluation of, are there ways or early markers for bladder cancer, maybe for all patients, maybe for at-risk patients, smokers, others. But we've not been able to identify that as of yet. And in fact, the urine is an ideal place to be able to potentially capture the cells, the molecules, the early indicators, but we still aren't at the point where we have a very reliable indicator.
I'm curious as to whether or not it's possible to detect microscopic amounts of blood at home. What I mean by that is we now have something called the fecal blood test, the occult blood test, and it's actually not that bad. Not as good as a colonoscopy, obviously, but it's a first step. Could people test their own urine at home for blood?
A good question, and in fact, an issue which has been addressed in the past. Does screening urinalysis, a dipstick, can we impact and detect bladder cancers? The answer is yes, we can by screening urinalysis. But the limitations of B, when we apply it to entire populations, does it make significant impact? And will there be false positives that lead to evaluations, maybe unnecessary evaluations? So that balance of trying to detect things early but not developing too many false positives where we're putting patients without disease through unnecessary tests is a tricky one.
And of course, this is an argument that people may be familiar with from other arenas, such as mammograms for detecting breast cancer, the PSA test for detecting prostate cancer. May give us false positives and false negatives as well.
That's right. And that I think we still in the area of bladder cancer similarly still struggle with that balance from an intervention standpoint, invasiveness standpoint, and potentially even from a healthcare cost standpoint.
So someone sees some blood in the urine. There are various causes, but obviously it gets their attention. We hope it does anyway, and they come to see you. Then what happens? So
that's to the next steps in the evaluation of blood in the urine. But I think to take one step back, I think that statement, what I tend to see too often and is that when people do have the sign or symptom of blood in the urine, they'll ignore it for a while. And I think getting the word out, getting the information out to that patient that don't ignore this, seek attention to this. But I think none of us, we want to kind of turn a blind eye to some of these symptoms, not go down that road. But the patient that seeks early attention to it, when they go see their physician, they'll get two basic steps in the evaluation. One is a CT scan, which looks for causes above the bladder for blood in the urine. Kidney tumors, a completely different type of tumor, which often present with blood in the urine. Kidney stones, other anomalies of the kidney and ureter. The second step in the evaluation is a direct evaluation of the bladder, and that's done through a test called a cystoscopy, which is putting a small scope, a flexible scope with a light at the end of it, a camera at the end of it, that allows us to directly visualize the internal lining of the bladder, and that is our most sensitive and specific method of determining bladder tumors.
Dr. Pruthi, somebody sees blood in the urine, they come to see you, you determine that there's something funny, maybe doesn't quite belong there. You go in, you take a look with cystoscopy, and you go, uh-oh, we've got problems. Now what?
The next step after we do the initial office cystoscopy, which is done under a local anesthetic and to identify the initial step that there may be something wrong, there may be a growth within the bladder, the next step is actually to do a biopsy under anesthesia. So a patient will be put under either a regional anesthesia, such as a spinal anesthesia or general anesthesia, and then we can take another scope, a working scope, so to speak, and go in there and excise that lesion, which does two things for us. Number one, it gives us and the pathologist tissue to make the determination, is this a cancer, and then other important prognostic information with that cancer. Number two, removal of that lesion or tumor, and our goal is actually often to completely remove it, is actually therapeutic in and of itself for many cases.
Similar to removing a polyp that you find with a colonoscopy.
I think that analogy is a great one. A screening, initial screening, sigmoidoscopy, for example, you identify something, and then performing a more formal colonoscopy, where we're actually trying to eradicate the tumor, and get a specimen to evaluate for further decision making.
How successful are you? In other words, you said that things haven't changed that much in terms of the longevity with regard to bladder cancer, in large measure because people delay coming in to see you. But once someone comes in, let's say at a relatively early phase, how good is surgery, and is there anything beyond surgery that might prevent a recurrence?
So that initial evaluation of the tumor really sends us in a lot of different directions. And what we do is we analyze that tumor similar to, like, as you said, in a colonoscopy. Is it a polyp? Is it a low-grade tumor? Or is it an aggressive invasive tumor? In the case of bladder cancer, 3 out of 4 of the tumors are non-invasive. So they're just on that inner lining. And in those cases, we really stratify them into low risk and high risk. And as the names would suggest, a low-risk tumor, simply putting the scope in and resecting it is very effective. In and of itself can result in a cure. For some more higher-risk tumors still on that lining, we sometimes deliver a secondary adjuvant therapy, which is putting medicines directly into the bladder. The fortunate thing about the bladder is because we have access to the outside, we can actually deliver a medicine, almost a topical type of medicine, to the inner lining of the bladder, which doesn't have systemic effects throughout the body. So we can actually use chemotherapeutic agents or even immunotherapeutic agents that create an immune reaction just on that inner lining of the bladder that can help fight that cancer and prevent recurrences.
You're listening to Dr. Raj Pruthi, Professor of Surgery and Urology at the University of North Carolina School of Medicine. He chairs the Department of Urology and is co-director of the Urologic Oncology Program and Bladder Cancer Center of Excellence at the University of North Carolina Lineberger Comprehensive Cancer Center. Dr. Pruthi serves on the editorial board for several journals, including the Journal of Urology, and he's also a member of numerous guidelines committees for the treatment of bladder cancer and urologic diseases.
And the point Dr. Pruthi has made, as well as our guest David Langham, the cancer survivor, suggests that blood in the urine is the red flag.
Literally.
We need to take a short break. When we come back, we'll find out more about how immunotherapy is used for bladder cancer.
Women are not exempt from this disease. How's it different for them?
Does lifestyle matter? We'll also find out about the greatest strides in bladder cancer treatment going forward.
You're listening to The People's Pharmacy with Joe and Terry Graydon. Welcome back to The People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is brought to you in part by Redix Industries, makers of utterly smooth foot cream with shea butter, helping dry, cracked feet feel soft and smooth. The number's 800-345-7339, online at uttercream.com.
And by We Patients, where you can learn from others about possible triggers and potential treatments for your headaches or migraines. Online at wepatients.com.
To order a CD of today's show or any People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 937, or find it online at peoplespharmacy.com.
Today, our topic is bladder cancer. We're talking to one of the country's leading experts. Dr. Raj Pruthi is Professor of Surgery and Urology at the University of North Carolina School of Medicine. He chairs the Department of Urology and is co-director of the Urologic Oncology Program and Bladder Cancer Center of Excellence at the University of North Carolina Lineberger Comprehensive Cancer Center. Just before the break, we were discussing bladder cancer treatment.
What's your success rate? In other words, if we were talking to a surgeon who dealt with lung cancer, that surgeon is going to say, if I can keep people alive for 5 years, I consider that pretty astonishing. My success rate is 10% or 5%. You're in a different ballgame.
We are, and because it is a very heterogeneous type of tumor, meaning there's a lot of different types of bladder cancer. The low-risk bladder cancer, we do a very good job. And in fact, 95% of them, we can prevent them from progressing, meaning spreading outside the bladder. The trick in bladder tumors, though, is although 95% of those low-risk tumors won't progress, about half of them will recur, meaning they'll come back. So sometimes that's the trick. Again, going back to the colon polyp analogy, we can control it, but it may keep coming back. Now, the second type of bladder cancer is that high-risk bladder cancer. And those are the ones that are going to want to work their way through into the bladder wall and then outside. And those are much more of a challenge because by the time they get into the bladder wall itself, the muscular wall of the bladder, the treatments really step up as far as their level of invasiveness because the curability becomes much more limited. When tumors become confined to the bladder but invasive into the bladder wall, these high-risk tumors, we start talking about more radical treatments, radical surgery, and even in those cases, even in the most aggressive cases, our cure rates are about 50%.
You mentioned surgery. Is that the primary treatment then for these high-risk cases, or do you then have other treatments that you add after surgery?
Yeah, and we've evolved, as I think we have in a variety of different cancers, to utilize what we term multimodal approaches, rather than have just one tool in our tool belt to look at the medical oncologist, the radiation oncologist, and the surgeons and see what combination is going to result in the highest chance of cure for these patients. And I think for these aggressive cancers, that's a very valid approach because we need to do everything to keep that patient, number one, alive, and number two, try to maintain their long-term quality of life. And those are tricky things to do, but those are the goals for every patient, is to try to obtain all of those goals. So surgery for invasive bladder cancer tends to be the mainstay of treatment. We have a lot of innovative ways, robotics and et cetera, that we're using to try to minimize the morbidity to patients and get them back to, again, work and a quality of life in a more rapid fashion. We also sometimes will add chemotherapy either before or after surgery, again, to try to get us do everything we can to try to optimize their curability.
What about the role of immunotherapy? I seem to recall learning about BCG vaccination 20, 30 years ago.
Yeah.
Does that work?
It does. It's a very, very interesting concept. So for patients who are not yet invasive, who are a little higher risk, whose tumors are on that lining of the bladder, as I mentioned, the first step is to remove the tumor. Once the pathologist tells us we've removed it, but hey, these have some high-risk features to it, we want to do a little bit more to try to prevent recurrence and progression for that patient. We don't want them to get invasive where they're going to need radical surgery. The best option for us is immunotherapy, as you suggest, using BCG. Now, BCG is an attenuated tuberculosis vaccine, often used in Europe as a vaccine for TB historically.
And it's been around for?
It's been around for decades, as you said. And in fact, in the mid-1970s, a physician by the name of Morales up in Canada had a very innovative idea, and I don't know what led him to decide to put TB vaccine within the bladder, but it was a very clever notion. And when he did that, the goal of delivering this TB vaccine into the bladder isn't that the vaccine itself is directly going to attack the microscopic cancer cells, but it's going to initiate an immune response, stimulating our own immune system to fight the vaccine, which also seems to fight the cancer, the maybe remaining microscopic cancer cells within the lining. And in fact, BCG therapy, and the way it's delivered, it's just a couple of tablespoons through a catheter in the bladder once a week for 6 weeks is the regimen. So relatively easy to deliver, and that remains frontline therapy for more high-risk, non-invasive bladder cancer.
And how effective?
Well, again, it depends on the stage and grade of the disease. But for patients who, for example, have very malignant-looking aggressive cells but still on the internal lining, it can have long-term disease-free survival from 50 to 75% for those patients, which is a lot better than most of our treatments.
The idea that what you're actually trying to do is remove the tumor in the bladder and then stimulate the immune system to get whatever's left, wherever it may be. And that's worked pretty well in the bladder.
Yeah.
It seems like we need that kind of immune stimulation for other kinds of cancers as well.
Yeah. I mean, and the fundamental issue with cancer, as you know, is it's your own body. And it's your own body going wrong. It's not an external bacteria. It's not a transplanted organ. It's your own body. So how do we differentiate the bad cells in your body from the rest of your body? And that remains to be a challenge. And a lot of the molecular and targeted therapies have done that. What genetically or molecularly has gone wrong in those cells versus the normal cells? And if we can identify that, then we can target those cells. Utilizing our immune system, it surveys things that are external to us. Can we utilize that to also survey internal, abnormal cells as well?
We've interviewed Nick Shaheen in gastroenterology, and we find his radio frequency ablation technique of the esophagus for things like Barrett's esophagus fascinating, because he says, I'm not getting all the cells. I know I'm not. But after I do the procedure, they're all going away. So there's something that's happening with that immune process to trigger beyond the area of the specific treatment an immune reaction.
Yeah, and I think in general, I do believe that in the last set of 10, 15, 20 years, we're beginning to think beyond things so simplistically as that.
Now, you mentioned that bladder cancer is more common in men than it is in women, but I understand that women may show up with more advanced tumors and thus have a worse prognosis. Why?
So the ratio, as you suggested, is more common for men than women, about a 3-to-1 ratio favoring, so to speak, men over women. There's some data that suggests maybe that those ratios are evening out a little bit, and there's a lot of theory behind that. Maybe in the 1970s and 80s, as women were beginning to engage in more smoking, that they were exposing themselves to tobacco abuse. To the risks of bladder cancer. But you're right; it still remains a 3-to-1 ratio. Although women have a less of an incidence of bladder cancer, in advanced bladder cancer or invasive bladder cancer, they do seem to present with more advanced stage disease. The feeling behind that isn't necessarily that the biology of their tumor is worse. It's more, it seems, that they're presenting a little bit later than men do. Why is that? That remains unclear. And an interesting adjunct to this is when we just talked about the effect of male and female on incidence. It's also been shown that Caucasian have the highest risk of bladder cancer, followed by African American and Hispanics. Nevertheless, if you look at all of the demographic subgroups, the patients that present with the most advanced stage disease are African American females. So going back to your point that females, there may not be something about the biology, but they often seem to be presenting at more advanced stage of disease. And it's unclear why that is. Is it access to health care? Is it symptomatology? It remains unclear.
What's so fascinating about this is that you think of women being much more proactive in general when it comes to their health, going in for their mammograms, having a regular physical, seeing their doctor if something isn't quite right, and men denying, it'll go away, I'll wait a while, and that, turns out to be 6 months or a year. But you're saying in this case, it turns out that women are actually maybe coming in later, and when they do come in, it's worse.
Yeah, and it's not to make it clear, it's not a very dramatic finding, but it's a subtle finding in the way patients are presenting. I don't know that we know why that is. The one observation I have as somebody who takes care of these patients is often women have recurrent urinary tract infections. That's not an uncommon phenomenon in women. It is uncommon in men, and I do observe that often women are treated for infection after infection when they never really had the infection. They may have actually been demonstrating early signs and symptoms of bladder cancer, and perhaps we were ignoring those for a while.
I think a lot of people may, as a result of this show, be paying more attention to bladder cancer that perhaps hasn't gotten as much attention as so many other cancers. And I think a lot of people are going to say, Dr. Pruthi, what can we do proactively to prevent developing bladder cancer? Are there any lifestyle issues? I mean, we certainly know that smoking is a problem for lung cancer, for other cancers, so that's number one. But what else can people do?
Yeah, smoking is the most important. And then to that point is even if you are a smoker, smoking cessation has a lot of important effects. And we know that. We have a lot of mechanisms to enhance our smoking cessation. So it helps your lungs from a breathing standpoint, an emphysema standpoint, from a lung cancer standpoint, but from a bladder cancer standpoint. A lot of patients I see never knew that association of smoking and bladder cancer. So just awareness in that regard. And I think just being in tune with your body and understanding the symptoms of your body, what's right and what's not right. Void urinating in a different way, frequency, urgency, blood in the urine, and I need to pay attention to that.
Let me also ask you about pain, because one of the things that women who have had urinary tract infections know is that with an infection, blood in the urine is almost always associated with pain. Is that also the case for when it becomes a symptom of bladder cancer?
It can be. And so painful urination can be a symptom of bladder cancer. And I think what's important then is, number one, to see your physician and have an infection ruled out. Because if you don't have an infection, you don't need number one, unnecessary antibiotics. And number two, then we need to begin to pursue these other potential diagnoses. And to go back to your point of being informed, I think it's a very interesting thing. As we said earlier, it is the fourth most common cancer in men. And an awareness issue is where we significantly lack in bladder cancer. We lack it from a patient perspective. I think we lack it from a funding perspective. We touched on earlier how it is one of the cancers I can think of in my practice that we have reversible causes. We have environmental causes. We have areas where I think as a field, a research field, we can make significant impacts, yet we don't. And there hasn't been a lot of attention from even the funding standpoint to bladder cancer. Bladder cancer, despite that high incidence, it ranks 23rd in NIH funding, despite being the fourth most common cancer in men. Yet, when you look at the cost of bladder cancer, because it is so prevalent, it is third or fourth in NIH expenditures and actually has the highest per patient treatment costs of any cancer. So what I'm getting at is, here's a common cancer that's expensive, that is potentially reversible from an environmental cause and a standpoint, yet we're not putting the emphasis behind that from a research standpoint and a funding standpoint.
Dr. Pruthi, where are you making the most progress in bladder cancer?
I think there are two things to me that are important, and they're relatively simple. One is something we alluded to before, and that is this concept of a multidisciplinary approach to cancers, having a lot of intelligent people sitting around a room, because we all come from different schools of thought. Surgeons think of things a certain way, not a wrong way, but that's the way. That's why we went into surgery, and that's our literature and our thinking, and radiation oncologists and medical oncologists, and getting other people, support people, nutritionists. We're getting nutritionists early and early involved in patients and looking at the patient as a whole, not as a kidney or a prostate, and how can we augment these things. But I think this broad, multidisciplinary look at a patient and coming up with a combined decision process for them is maybe some of the greatest advancements we can provide. So it's not a specific thing as putting all of our heads together and coming up with a more broad game plan in that patient's best interest. The other attention I think that is very, very important that we're doing is we always talk about issues of cure and not cure and recurrence and disease-specific survivals. But this concept also of looking at patients beyond that from issues of quality of life, I think, are very, very important for patients. Whether it does take two extremes, a patient where we cure them and we see them 5 and 10 years out and we can pat ourselves on the back and feel good about that, and we should feel good about that. We've come a long way and cure rates have improved. But can we start to look beyond that and say, how can we also now look at how we've impacted them long term and minimize that intervention that we did, the impact to their quality of life? So I want to cure you, but also I want you to go on with your life and do everything that you want to do and not have that impact to quality of life, and that the concept of survivorship. And I think it's a very important one that we do. And the other extreme is even for the patient with the most advanced cancers, what else can we be looking at them from a quality of life standpoint? Beyond cure, beyond treatment, I mean, those things are important, but sometimes even for the patient with a more limited life expectancy, what can we do to help them from a nutritional standpoint, from a quality of life standpoint? And I think those are very, very important goals going beyond what we think traditionally of in cancer care. There are other interesting things that are happening even from the patient support standpoint. In the Triangle now, we have a bladder cancer patient support group. And in fact, there's a national organization. It's called Beacon, BCAN, Bladder Cancer Advocacy Network. There's a few of them, but it's probably the largest bladder cancer patient advocacy group in the country. And the fact that, number one, it exists and is really, to me, for somebody who takes care of these patients, very, very heartening.
Is there a website?
I believe it's beacon.org, BCAN.org. But this is a group of patients that, not to take away from the tremendous support that other cancers, lung, prostate, and breast should get, but in a way, a cancer that is so common that really hasn't seen the attention. And it's wonderful, I think, when patients can get together, lean on each other, rely on each other, talk to each other. There's really no substitute for that. And we're beginning to see that in the area of bladder cancer. And I think that's, again, a very important step, a grassroots movement of sorts for patients themselves to advocate for themselves.
Dr. Raj Pruthi, thank you so much for talking with us on the People's Pharmacy today.
Thank you for having me.
You've been listening to Dr. Raj Pruthi, professor of surgery and urology at the University of North Carolina School of Medicine. He chairs the Department of Urology and is co-director of the Urologic Oncology Program and Bladder Cancer Center of Excellence at the University of North Carolina Lineberger Comprehensive Cancer Center.
We spoke earlier with David Langham, bladder cancer survivor and coordinator of the Triangle Bladder Cancer Support Group.
Lynn Siegel produced today's show. Al Wodarski engineers the program. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
If you would like to order a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 937. That number again is 800-732-2334. You can also place the order on our website, peoplespharmacy.com.
And when you visit the site, you can listen to an extended interview with David Langham. You'll also find links to Beacon and Triangle Bladder Cancer Support Group.
You can check out prescription drugs, herbal medicines, and home remedies. Sign up for our free online newsletter or the free podcast of the show. You never need miss another People's Pharmacy program again, and you can share it with a friend. It's all there at peoplespharmacy.com.
In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thanks for listening, and please do join us again next week.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to the People's Pharmacy.